Thanks so much, Rayanne. I really appreciate the opportunity to be here and for your really kind introduction and for Marcia's words and Francine's words as well. I totally agree that gratitude is the word for the day and maybe every day. And I'm really grateful to have the opportunity to be with everyone today and to have the opportunity to work on these really important health topics in an effort to improve health for all people. So I'm going to try to share my screen. Hopefully my sound is okay and the screen is okay, but please let me know if it is too loud or not loud enough, and also if it is too small. So as Rayanne mentioned, I'm going to be talking about the what's internally called the Strong Heart Stroke Study, which is more officially or formally called the Cerebrovascular Disease and its Consequences in American Indian Study, which is an ancillary cohort within the Strong Heart Study. Rayanne did a really excellent job of sharing a bio. So when I wrote this talk, I wanted to share a little bit of my personal background just to introduce myself to you all so that you know who I am and where I come from. I grew up in West Texas, but I moved around a bit as a little kid. I also lived in New Mexico, Louisiana, and Oklahoma. I did college in Massachusetts. I studied history and biology, and then went to have a PhD in Seattle at the University of Washington, as Rayanne mentioned, and now work at the Washington State University College of Medicine. Those pictures are Big Bend National Park, which is in Southwest Texas, and it's one of the most beautiful places, I think, on earth. And then I also like to do pottery in my free time as well, which Rayanne didn't mention, but those are some of my recent pots, which is really fun to do. Some of my research is focused on, well, my research is generally focused on health disparities. Some of it is on brain aging, in particular brain imaging, cognitive testing, and biomarkers. That's mostly what I'll be talking about today. As we were kind of chatting about earlier, I had written a longer talk that I don't think would fit into the time that we have together. So some of my other projects, the protective brain aging on social support and resilience, we'll have to wait for another opportunity for me to share those results with everyone. And then there's other specific ongoing projects looking at cognitive validations, a larger resilience project, a toolbox project looking at stress, more biomarkers and imaging projects that are ongoing. And so in the future, I'd love to be able to talk about those as well. Some of the background to the work that I'll be talking about today is looking at risk exposures for brain aging or health disparities in brain aging. It's known that early life exposures such as education, midlife, such as hearing loss, traumatic brain injury, hypertension, heavy alcohol use, and obesity, late life exposures like smoking, depression, social isolation, physical inactivity, air pollution, and diabetes, and then non-modifiable risk factors like ApoE genetics. These are all known to be risk factors in non-Hispanic whites. There's a graphic that you can probably not really read on the side there that kind of traces these exposures in a population level through time, through the life course. But these factors and other factors haven't really been studied in most minorities, including American Indian peoples. And so it's not really known whether these factors are key for American Indians or whether there's other factors. It also doesn't really look at presentation of dementia and Alzheimer's disease and vascular injury in American Indian peoples, which we didn't really know anything about. And so we were really interested in trying to understand these conditions and the risk for these conditions. And so that's what kind of made us interested in doing the Strong Heart Stroke Study and collecting these data and then understanding these data. So another kind of background piece is that measuring cognition is very challenging. In any people, it's difficult to do because the gold standard for doing that is to sit with a trained neuropsychologist or a physician for several hours and have them assess cognition in a kind of dynamic manner, which is not practical for many scenarios. And so what's done generally in clinic and in research is to conduct standardized testing using, paper-based or computer-based tests, and then to evaluate the scores from those tests in some kind of typical manner, and then look at those scores either for those individuals or across a population to assess, prevalence of dementia in that population. But in some populations, these tests don't necessarily work as well as in the populations those tests were developed for. And that's due to what's called confounding effects. And those are indirect effects that might influence testing in a way that's not related directly to actual cognition. And those might be things like social disadvantages, poor quality education, low income, psychological health, practice effect or test anxiety during the test, culture and language differences that might make it harder to understand or engage with the test content. And then of course, healthcare access and timing of the test itself. And so those are kind of those blue or those gray bubbles on the right there. And then the blue bubbles are what we're actually interested in, which is the actual cognitive status. And then the one on the bottom there is the cognitive test score, which is what we're actually measuring. And so those are what we're calling direct testing effects. And so these are things that we had to think about a lot as we were conducting this stroke study when we were trying to measure cognition and dementia in relation to vascular injury and Alzheimer's disease. So the kind of schematic for this study, the Strong Heart study phase 1 was conducted, it started in 1989. A number of people have survived in the 30 years since then to our visit 1, which started in 2010. We recruited about 1,000 people for that visit. After that visit, one community in the Southwest Center withdrew from all studies, leaving about 800 people for that visit that are currently consented to analysis. For our second visit, which occurred in started in 2017, we recruited about 400. So we have 800 and then 400 people in our 2 different visits that participated. For those 2 different visits, here at the bottom, I have a little bit of detail. They were majority female, which is consistent with a kind of aging population. We know that males are less likely to survive into older age than females. The ages were 64 and older at the first visit and 71 and older at the second. And then we conducted a number of different data collection points, including magnetic resonance imaging or brain imaging, which I'll talk about with kind of a blue header, just so that you can kind of track with color what I'm talking about throughout my talk. We did cognitive testing, which is that green, and then we collected other factors as well, like neurological and clinical history, mood, medications, and then typical clinical blood labs and urine labs. And those are in yellow there. So first I'll talk about our imaging protocols. These are some details. You don't have to necessarily understand these pictures, but I just wanted to show you kind of what they look like. We collected structural MRIs, which basically give you a picture of structures within the brain. You can look at things like atrophy or tissue loss, and then you can also look at things like vascular disease. And so those are the 2 things we really focused on. And so we had neuroradiologists look at these images and then grade these images for presence of white matter disease, for presence of large vascular lesions like infarcts or hemorrhages, and then to also grade them for what's called sulcal widening, which are those spaces between the brain folds, and then ventricle enlargement, which are those kind of spaces in the center of the brain. That's where the cerebrospinal fluid is generated. And then we also did software processing to establish estimates of volume for the whole brain, for specific regions of the brain, and in particular regions that are related to Alzheimer's disease, that are particularly targeted by Alzheimer's disease, so that we can look at whether those regions are the same for this population and whether people that have more atrophy in those regions or loss in those regions might have similar characteristics as people in other populations. Oh yeah, okay, so I'm still talking about the methods. So the cognitive testing here in green, we did 4 main cognitive tests at the first and the second exam. They basically covered general cognition, processing speed, tests of verbal learning and memory, and then verbal fluency, which is your ability to kind of come up with words in a timed exam. And then at the second visit, we added additional tests that are related to Alzheimer's disease. They're all listed here. They cover a number of different cognitive functions, or what are called cognitive domains, most of which are related to different aspects of Alzheimer's disease and which are targeted by Alzheimer's and related processes in Alzheimer's dementia. And then these kind of other measures that we collected included physical function, neurology and mood, like depression, quality of life, history of head trauma. We looked at medications and labs, as I mentioned, including things like glucose, creatinine, and cholesterol. And then here's the little summary of the time between the exams. The mean time was about 6.7 years. And about 405 people attended both exams, and 412 people were able only to attend the first exam. So here I'm getting into our first results. These are kind of what's called a table 1, or just a summary of data of the people that attended only the first exam there on the left, the people that attended the first exam who later would be able to attend the second, and then on the full right is the people that attended the second exam. And this is just an effort for me to look at whether there's bias between the groups, so that we can see whether there's something called selective survival or differences in people that were able or unable to attend both exams, and then of course changes over time in these features. We saw that people who were not able to attend both exams were older, had diabetes and kidney disease, compared to the people who later did attend the second exam, which suggests that there might be some selection going on. They were a little bit sicker. And then of course, that group that did attend the second exam, by their second visit, they did have worse hypertension, worse diabetes, and worse kidney disease. And so they look like they're aging over time, which is what you would expect. Looking at smoking and alcohol, these have been described previously in the Strong Heart study. And so, you know, I don't need to belabor these very much, but we just wanted to see whether they were similar to previous exams. There were 34% who had never smoked, 24% who had never drunk alcohol. The former or not recent drinkers were also largely prevalent. And so there were very few drinkers in our group, which is consistent with an aging population and consistent with previous reports. And so both of these also declined a little bit over time by our second examination. And so, you know, both were pretty infrequent, but there were some people that did have heavy use, but they were very few. Looking at education, education is a really important factor for contextualizing and understanding those standard cognitive test scores that I talked about earlier. And so this is a key factor. And education is supposed to measure this kind of crystallized function that develops throughout childhood into adulthood and then is consistent throughout adulthood. And that's measured here with something called a reading score. It's kind of abbreviated with the RAT score. And in a kind of sanity check, I examined whether they were strongly correlated, as they should be, and found that they actually were not. They were less correlated than in the general population. And that suggests a few things. That suggests that there might be informal sources of education or achievement in this population, that people might be, their reading score was higher than would be expected from their years of formal education level. And so it suggests that people are achieving more than their education level would suggest. And so it suggests that the education measure is not a good measure. And so we should actually focus when looking at cognitive tests on this RAT score, or maybe on other factors that are more correlated with what we're really interested in, which is the actual kind of baseline cognition. And so this is something that we need to, I think, work to understand better, and to use in contextualizing cognition, so that we can better understand cognitive testing in this population, because it looks like the education factor is not doing what it should be doing as it does in other populations. So a little bit of summary of these clinical findings so far. We did have a little bit of losses by our follow-up. Those who did not return were older, more diabetic, and had kidney disease. There were changes over time, and they included changes to hypertension, diabetes, and kidney disease. None of those findings were surprising. And we did have, few drinkers. Many had smoked, but few were still smoking. And the years of education, as I mentioned, was not a good predictor of baseline ability. And so we need a better predictor of baseline ability. So the next steps are to look at issues related to that education or achievement, that baseline ability. We need to examine how language, culture, and identity influence brain aging. And we need to look at more objective markers, especially things related to dementia and Alzheimer's disease. So here next, we're going to look at the imaging factors, which are a little bit more objective. So these data I have, I think, shared before, but these are really important data. We've found that self-reported prior stroke in the first exam was about 8%. History of brain injury was 30%, which was quite a bit higher than expected. Vascular disease, large vascular disease like infarcts and lacunar infarcts was about 30%, and it's similar for the white matter grade there, that like red bar. And then abnormal atrophy, such as the ventricle or sulcal grade, was about 2/3 of the population. And so those were a little bit higher than in the non-Hispanic white US population. Some of the changes over time between exams, we found that the group that did attend both exams, by the time of their second exam, did have more infarcts, more hemorrhages, more white matter lesions, and more atrophy. And that's kind of what you expect. You expect to see people over time aging a little bit and developing more brain conditions as they age. 7 years is not an unreasonable time to see a little bit more changes. And so we're working to understand how these changes compare, in rate to other populations, and to kind of flesh out these data a little bit. So some specifics on how fast these losses are changing. We did a within-person analysis of the MRIs over time, and we found that there was a mean about 0.5% loss per year. That's less than 1% loss per year in each person on average. So the actual range was somewhere between 0 and 1. Some people were a little bit more than that, but the linear loss was about 0.5% over time. And we found that it was similar by sex, it was similar across field centers, and it was not associated really with older ages. So it kind of looks like it's just declining in a linear manner, for people as they get older. So this is looking at quartiles of that loss factor, just like people with the most extreme loss versus less extreme loss, looking at some of those other factors. As I mentioned, sex and age didn't seem to affect it. We did have people with diabetes did have more brain volume loss. We did also look at outcomes like those kind of cognitive test scores, and we found that people that had more brain volume loss also had worse memory. And so these are really interesting data, and it suggests that diabetes is really important in this population for risk of dementia and vascular and Alzheimer's type dementias, and that some of the outcomes like memory type dementias could be really critical to that kind of diabetes vascular pathology. And so we're going to need to investigate this, I think, a little bit more, looking at that diabetes factor. So a little bit of summary of these findings so far. Compared to the US general population or non-Hispanic whites, there was similar atrophy, but there was more vascular disease. The pattern of MRI findings with with cognitive aging are similar as in the general population. I didn't show those data, but that's what we have found, that the association patterns are similar, but that there was a little bit more of some of the findings. And so that's a little bit different. In change over time, which are the new findings, we found that, some of those did increase over time. We also found that the linear loss was about 0.5% per year. Sex and age were not associated with the rate of loss, but that brain volume loss was worst among those with diabetes and was associated with worse memory. So the next steps here are to continue to look at brain imaging features, especially in relation to diabetes and one of its sequelae, which is kidney disease. We'd like to look at specific functional and regional associations, whether those, parts of the brain that are targeted by Alzheimer's disease are also specifically targeted by diabetes. There's also work looking at obesity with one of my colleagues, Dr. Anna Zamora Kapoor, and then looking at variability in cognition with Dr. Luciana Mascarenas Fonseca. And so we're kind of trying to expand on these findings and understand a little bit more about how these relate to the occurrence and presentation of dementia. And so next, we'll also kind of try to understand cognition, which is like that kind of big outcome that, really affects people's lives. So looking at cognitive and physical function at the first visit, these are just kind of general scores. They're contextualized, within the range of possible scores. And so the actual numbers are not terribly important, but generally we found that females had better verbal skills and verbal memory, and that males had better physical function and strength. And so these are kind of a little bit differences in the population. We looked at whether depression was associated with cognition, and we did find that depression symptoms were associated with worse cognitive test scores, especially processing speed, verbal skills, and physical function, which is kind of what you would expect. Depressed people might be more likely not to do well on testing, but it also kind of affects the dementia pathology. And so you might expect people with depression to be more at risk. And so it's kind of like that circular effect. We also looked at one genetic risk factor, which is a key risk factor in Alzheimer's disease that is one of the biggest risk factors besides age for Alzheimer's dementia in non-Hispanic whites. And we found something that was really surprising. In other populations and other minorities, it has been found to potentially not have any association, but those findings have been mixed. And so we wanted to look in American Indians and see whether there was any association, and we did not find any evidence of an association. There was no association of ApoE4 status with memory, with any kind of cognitive tests. There was no association with any of the imaging findings that we had done, the MRI. And we did find some positive controls, which makes us confident that this is not necessarily an error of the data, that we did find positive associations with blood LDL, blood cholesterol, and we did find that there was a similar level of ApoE4 as there would be in the general population and as there have been in previous visits, in the earlier visits of the Strong Heart study. And so that says to us, this is probably not a methods problem. This is probably a real effect, that there's not really a risk from ApoE in this older population. And so we weren't really sure how to interpret this, whether this is that people with the risk gene are being protected by something we don't know about, or is there an excess risk that's making people that are not exposed to that risk gene at higher risk, that's kind of making everybody look like they're about the same level of risk. And so I think this bears further investigation, to kind of find out what's going on here. Why is this different than, in other populations? We also looked at cognitive impairment. We tried to operationalize cognitive impairment. I've got some methods here that I included. I won't go through these just because I don't want to use up all of our time talking about, details. But these, we can look at these a little bit if we need to. And then just to define cognitive impairment a little bit using these like kind of this algorithm, we defined it with, people with kind of intact memory or so-called normal function, and then these deficits in memory that are characteristic more of neurodegeneration or Alzheimer's type memory problems, or vascular type memory problems that might be more like vascular injury, like infarcts or hemorrhages. And that doesn't mean that people with these problems necessarily have these conditions or don't have the other condition. It's just kind of more reminiscent. It's typical of those conditions. And so it gives us a first glance at how prevalent these or how common these conditions might be without being able to look at these conditions directly. And so, we looked at, this division of these memory problems, and we found that about 70% of people had intact memory defined in this way. About 14% had a retrieval deficit, 6.5 or 7% had a storage type deficit, and then 10 or 11% had an encoding deficit. And so collectively, 17% had, memory problems that are characteristic of neurodegeneration. And that's similar, but a slightly higher than the 14% that are observed in the general population. And so that's really encouraging that it's like kind of similar, but a little bit higher, which is maybe what you would expect considering that there are more risk factors in this population. We found, looking at age, sex, and education, that males are more likely to have the neurodegenerative or Alzheimer's type and the retrieval type of vascular deficits, whereas females are more likely to have the storage type of neurodegenerative deficits. And so those are really interesting differences. And I think that looking at those a little bit better, and then also being able to look at objective measures in imaging and in blood biomarkers would really help us to understand, whether these are really good divisions for these conditions and, how closely they are related to those actual pathologies. So a little summary of our cognitive findings so far. We found that females generally had better verbal memory skills. Males had better physical function and skills. Depression was associated with cognition as we expected. There was no association with ApoE for gene, which is not what we expected. Using that kind of memory impairment definition, we found that, possibly 31% had some memory impairment. 17% had a pattern that was characteristic of Alzheimer's disease type impairments. And that's compared to 14% in the general population, which is a fairly similar number. Males had more vascular and more of an encoding type problem, and females had more of a kind of storage type problem. And looking at the prior work with the cognitive scores with the MRI, this is consistent. Generally, these findings are consistent with the US population, the associations. Vessel disease is associated with processing speed. Hemorrhages is associated with processing speed and memory, and brain atrophy is associated with verbal fluency. And then, of course, age affects these associations. So some of the next steps we'd like to do are to establish kind of normal values for these cognitive tests. We'd like to look at test adaptations, whether culture, language, community, education, whether those influence tests and whether we can adapt these tests, for more appropriate and more sensitive use in community settings. We'd like to measure younger and more urban populations. My colleague, Dr. Lonnie Nelson, is doing some of that work already. And we'd like to continue to examine psychological, social, and resilience factors. I haven't mentioned any of that work yet because, we don't really have time today. But there is a lot of ongoing work to look at the social and kind of so-called strength factors. And I think that that's really important work to understand the kind of flip side of risk, to understand the strength that makes some people age better than others, and to potentially identify factors that help everyone to age better. And then to better understand these genomic risks, why is ApoE not associated, and are there other genetic risks that are associated, and are there things that we can do to intervene? And what are those protective factors? Is there nutrition? ApoE is a lipid metabolism gene, and so is there like nutrition or traditional foods that might be protecting some people? And then to develop methods to improve analysis. My colleague, Dr. Linda Valeri, has a project in review right now to do some of that work as well. So some of my summary overall, I'll fly through this because I've already kind of iterated these already, but generally this, the strengths of this work is that this is a complete cohort. It represents, all of those people who have survived. It's longitudinal, it's detailed, we have objective and standardized data, but some of the limitations are that this is a survival cohort. We have some measurement issues that we're trying to overcome. We have some validation issues that we're trying to overcome, and so these cognitive domains, there may be features that are not well measured, and we're trying to understand that better as well. So summary overall, these lessons, we know that vascular and Alzheimer's disease may be higher than US population, but the patterns of association are similar, barring that genetic effect. And so next we'd like to understand the influences of education, culture, language, identify objective measures, to look at cognitive test validity, and to identify, other risks that we haven't yet understood fully, and to consider those protective factors. So at this point, I think flying all through this presentation, I'd like to stop and give everyone a chance to ask any questions, and to also just thank you again for listening and giving me the chance to share this work. So thank you.